5 o'clock, so I think we should get started. We've got a few people here, and I believe it's recorded for those that can't make it in real time. So for those of you who are joining and haven't met me before, I'm David. I'm the anaesthetist at London Vet Specialists. And today I'm going to present a few papers, mostly focusing on how we can improve post-operative or post-anaesthetic oxygenation in dogs undergoing a variety of procedures or a variety of anaesthetic management, and techniques by which we can try and improve that if we have problems with hypoxemia. So I selected 4 papers and I've uploaded them on Teams, and then I've changed the order a little bit, so if anybody's following with the papers in front of them, I'm going to start with the one that was ranked 3rd and then move on to 1, 2, 4. Sorry for the confusion on that part. And before we go into it, I'm just going to define a couple of, or give a couple of definitions and concepts that the papers focus on, and just to make it a little bit easier for the understanding if people aren't too familiar with these terms. So the first one is atelectasis, which is complete collapse or incomplete expansion of the pulmonary parenchyma, notably of the alveoli, the gas exchanging unit. And there are 2 main types of atelectasis. The first one, which we'll focus on through these papers, is absorption atelectasis. And that happens when a rapidly absorbable gas, such as oxygen, moves from the alveolus into the pulmonary bloodstream and causes the alveolus to deflate. This usually happens when the airway which serves that alveolus is compromised. So I've just, forgive the drawing, but a little depiction of what happens. So when an animal or a person is breathing room air, there is a mixture of nitrogen and oxygen in that gas. And the oxygen is very soluble. And because the capillary blood is deficient in oxygen, that oxygen wants to rush from the alveolus into the capillary bloodstream. So that happens, and then if you look at the image on the right, the nitrogen, which is quite insoluble, it remains within the alveolus and kind of acts as a sort of skeleton to keep that alveolus inflated and ready to be replenished with fresh gas at the next breath. What happens under anaesthesia, particularly in veterinary medicine, we tend to use very high fractions of oxygen as a carrier gas for the volatile agent. And in most cases, that's going to be 100% oxygen. So what happens in this case is that the image on the left is initially similar. So the alveolus is open and full of highly soluble oxygen. But because that rushes into the oxygen-poor pulmonary circulation, this leads to deflation of the alveolus, and when the walls come close together, they can tend to adhere, and that alveolus can collapse, and that is absorption atelectasis. And the second main type of atelectasis is compression atelectasis, which is a mechanical compression of the pulmonary parenchyma, and that can happen in disease states such as pleural effusion or pneumothorax, but relevant to veterinary anaesthetists and people who are doing laparoscopic surgery. The distension of the abdomen causes cranial displacement of the diaphragm, which puts direct pressure on the lungs and leads to compression atelectasis. So we have a mixture of both, probably during laparoscopic procedures particularly. The next, or the consequence of atelectasis, is that it creates something called an intrapulmonary shunt. And the intrapulmonary shunt occurs when areas of atelectic lung are still receiving blood supply from the right side of the heart, but because there is no gas supply to that collapsed alveolus, and the blood remains oxygen poor as it moves through the lung and back to the systemic circulation. There's a little depiction here. So the alveolus on the right is functioning normally. It's open, it's got oxygen in it, and that oxygen is moving into the capillary blood and then to the systemic circulation to nourish the systemic organs. But the alveolus on the left of the picture has collapsed and doesn't have any oxygen to give to the capillary blood. So that remains poor in oxygen. This then mixes with the well-oxygenated blood within the left ventricle. and creates a shunt, so a decrease in oxygen tension overall. And one additional problem associated with atelectasis, particularly with mechanical ventilation, but also during spontaneous ventilation, when that lung unit, the alveolus, collapses, the walls stick to one another, and then when the next inspiration comes along, whether it's spontaneous or mechanical, that pops open that alveolus again, and this can get into a vicious cycle which we call recruitment, de-recruitment, where the alveolus is continuously collapsing, sticking together, and then being popped open. And this can cause damage to the alveolar unit if it is happening repeatedly. Throughout these papers, they will mention different ways that we can assess lung function, and the ones that they mainly talk about are highlighted here. So probably the most straightforward one is the PaO2 or the PaCO2, which is the partial pressure of oxygen or carbon dioxide, respectively, which is dissolved in the plasma. And they will also look at the AA difference, so that's the alveolar arterial difference, or sometimes called the AA gradient, and that's the difference in partial pressures of oxygen within the alveolus compared to the arterial plasma. So there is usually a small difference in pressure which drives oxygen from the alveolus to the bloodstream. Additionally, they'll talk about the PaO2 FiO2 ratio, or abbreviated to the PF ratio, and that is the ratio of arterial oxygen tension in millimeters of mercury to inspired oxygen fraction rather than percentage. So we're talking about breathing room air, where we talk about an oxygen fraction of 0.2 rather than 20%. In the later paper, they will mention shunt fraction, and that is the proportion of the cardiac output which is not taking part in gas exchange. And finally, so those first four are to do with gas exchange, and this fifth term, lung compliance, is how easily the lung expands. So it's the degree of lung volume change per unit of pressure change. So now that we've kind of run through those definitions, we'll move on to the first paper, which is looking at the effect of two fractions of inspired oxygen during anaesthesia on early post-anaesthesia oxygenation in healthy dogs. And so the sort of concept behind this surgery, as we touched on briefly with our definitions, general anaesthesia has a negative effect on lung function overall. And this is due to muscle weakness causing relaxation of the diaphragm, which causes a reduction in the functional residual capacity, which is the volume of gas which remains within the lung at the end of a normal expiration. When that volume decreases because of the movement of the flaccid diaphragm, it moves towards what we call the closing capacity, which is the volume at which small airways tend to collapse. So during anaesthesia, we get this small bronchiolar collapse, which traps gas within the alveolus, leading to absorption atelectasis, which we described a couple of slides ago, inevitably causing an increase in pulmonary shunt. So highly soluble gases such as oxygen or nitrous oxide move easily from the alveolus into the capillary circulation, and therefore they promote this absorption atelectasis, whereas insoluble nitrogen can help to prevent it because it doesn't very readily cross the alveolar barrier. In human patients, post-anaesthetic hypoxemia is a frequent complication, and that is likely to be multifactorial, due in part to hypoventilation, either caused by the residual effects of sedation or anaesthetic agents or analgesic agents, as well as by pain inhibiting expansion of the chest wall. It's also caused by an increase in oxygen consumption. Patients are often hypothermic post-operatively, and the shivering puts a massive increase in oxygen demand from the skeletal muscle. And finally, intubation and prolonged recumbency promotes this atelectasis and subsequent shunting of blood from the right side of the heart to the left without picking up oxygen. So can we use nitrogen as an insoluble gas to reduce the atelectasis and therefore improve post-anaesthetic oxygenation? And the hypothesis from these authors was that by reducing the inspired oxygen fraction with the addition of nitrogen, and that they will improve the post-operative oxygenation. So in terms of study design, they recruited 22 healthy dogs which were having an ovarian hysterectomy through midline ciliotomy, and the animals were randomly assigned to receive either 0.4 or greater than 0.9 inspired oxygen fraction. They were treated in the same way initially, so they received intramuscular dexmedetomidine and hydromorphone, induced with propofol, and maintained with isoflurane in their oxygen or oxygen-air mixture. The anaesthetist in charge of the case was allowed to adjust the volatile agent to maintain appropriate anaesthetic depth and give pressure support drugs if required. However, a situation requiring additional analgesic agents or the use of mechanical ventilation would lead the dogs to be excluded from the study. At the end of the surgery, the animals were extubated and recovered in left lateral recumbency, breathing room air, and additional analgesics were given at this stage. And prior to abdominal closure, they took their first arterial blood sample. So for data collection, as I mentioned, they took arterial blood gases, and the first one at the closure of the abdomen while the dogs were still intubated and breathing their oxygen mixtures, and then at 5, 20, and 60 minutes after extubation. Outcomes measured included the arterial partial pressure of carbon dioxide and oxygen, the alveolar arterial oxygen difference, and the PF ratio, along with the sedation score for the patient, which is one that the authors had designed themselves, and it's shown there in the table. So moving on to results from this paper, from looking at the groups to make sure that they were similar, and there was no complication caused by assignment to groups which were inherently different. There was no significant difference in the demographics of the group populations, nor in the dose of propofol or isoflurane required, or in the PF ratio intra-op. They did find that the PaO2 and the alveolar arterial oxygen difference was significantly lower in the group receiving 40% oxygen, which at this stage is not surprising because simply because of the pressure driving oxygenation of the blood between these two groups. So at this point, they're not really looking at differences in alveolar atelectasis. So moving on to the recovery period, so 5 minutes, 20 minutes, and 60 minutes after extubation, further arterial blood samples were taken, and this is when both dogs were being treated the same again, so both breathing just room air. And the black bars represent the group that had been breathing 40% oxygen. The white bars represent the dogs having received greater than 90% oxygen. And they didn't detect any significant difference in arterial oxygen concentration between the groups at any of these time points. And across time points, there was no significant change in the arterial tension of oxygen. When they looked at CO2, again, there was no significant difference between the groups. And the only difference that they noticed was that the CO2 was higher at 5 minutes compared to 20 and 60 minutes, which again is not too surprising. And it does correlate with a reduction in the sedation score that they were measuring as well. So as the dogs became more awake, they were able to eliminate more carbon dioxide. So in terms of discussion and conclusion, the results do not support their hypothesis, which was that the animals breathing a lower fraction of oxygen would suffer less oxygenation crisis. They found that the addition of nitrogen did not improve the immediate post-operative gas exchange in dogs. This doesn't agree with some information which supported their study, which showed that the addition of nitrogen to the gas mixture had been shown to reduce atelectasis in humans and dogs. That was based on CT findings, but in this case that doesn't translate into gas exchange effects. And also in the human literature, the effect of gas fractions on postoperative lung function is still unclear or debated. Some studies show that a lower fraction improves oxygenation, but it's not consistently shown. So as their conclusion, they cannot support the use of nitrogen to prevent hypoxemia in the postoperative period. They suggested that if the atelectasis, there may have been some reduction in atelectasis in the low oxygen groups, but because of the higher fraction of oxygen in the alveoli, which were still functional, that may have compensated for small amounts of atelectasis. As a side point, they noted that 3 of the dogs developed hypoxemia with an arterial oxygen pressure less than 80 millimeters of mercury. One of these dogs was, 2 of these dogs were at a 5-minute time period, 1 each in the control and 1 in the test group, and then a further control dog was still hypoxemic at 20 minutes. And they suggested that although the hypoxemia was mild, all of the dogs recovered without intervention, but it emphasises the importance of monitoring oxygenation in the immediate post-op period. So moving on to the second paper, which is actually by the same authors. So I think they weren't particularly happy with their findings in the first paper, so they wanted to explore this a little bit further. So they were looking at post-operative oxygenation in healthy dogs, which were undergoing mechanical ventilation during their anaesthetic with inspired oxygen fractions of 0.4 or greater than 0.9. So the difference in this one is that the animals were mechanically ventilated rather than allowed to breathe spontaneously. So again, just the rationale behind the study is because anaesthetic can lead to small airway closure and pulmonary shunting and hypoxemia. Yeah, this is basically just to recap a similar introduction to the first paper. So the nitrogen is supposed to hold open the alveolus and allow better gas exchange post-operatively. So the motivation for this study compared to the first one is that when you use mechanical ventilation, the diaphragm becomes redundant, and therefore there is no muscular tone in it. And this may worsen atelectasis during anaesthesia. If the dogs are breathing spontaneously, then the diaphragm maintains its tone, and this functional residual capacity that we spoke about earlier is higher, and may decrease the amount of atelectasis. So the new hypothesis is that the use of a low FiO2 would result in less atelectasis, and therefore less hypoxemia in the first 4 hours post-anaesthetic. So they also increased the time that the dogs were monitored after anaesthetic in this case. But the methodology was quite similar. So they took 20 healthy female dogs, again undergoing ovariectomy, randomized to either the control or test group. Anaesthetic and pre-medication and induction was the same. In this case, the mechanical ventilation was set at 12 milliliters per kilo for tidal volume, at 10 breaths per minute, with an inspiratory-expiratory ratio of 1 to 2.5. And this was set in stone. So it's a bit unusual compared to other studies which look at ventilation, where they tend to then adjust that baseline ventilation based on the end tidal CO2. So these dogs received this ventilation strategy regardless of the consequence on the blood gases. In this case, the anaesthetist was allowed to adjust the volatile agent and pressure support drugs as required, but interestingly also to administer additional analgesics, which in the first study would have caused the animal to be excluded from the study. But by chance, no additional analgesics were needed to be given to any dog, so that stopped that from being a confounding factor. The dogs were all weaned from mechanical ventilation at the end of surgery with 1 manual breath per minute until spontaneous respiration returned. and all dogs did resume spontaneous respiration within that 1 minute. So again, they were extubated and recovered in left lateral recumbency, breathing room air, and given additional analgesics at this point. So again, they took a blood sample at the closure of the linea alba and on analysis found no difference between group demographics on anaesthetic duration, drug doses used, or the mean end-tidal CO2 throughout the surgery, or peak inspiratory pressures required, which suggests that the compliance of both dogs the lung compliance of both dogs was similar. And again, they found that intraoperatively, the PaO2 was significantly lower in the group receiving less oxygen, so not surprising. However, compared to their first study, they did dogs which are certainly far more dogs which were hypoxemic in the recovery period. So that in this graph, the circles are the groups receiving high fraction of oxygen, the triangles are receiving the restricted oxygen of 40%, and the white circles and triangles are dogs which are normoxemic, the black ones are hypoxemic. So there weren't any statistically significant differences between groups at any time point. However, the arterial oxygen tension was significantly higher at 60 minutes than at 5 minutes. So this again ties in probably with, as the animal wakes up, they begin to ventilate better and are therefore able to oxygenate their blood better. A similar graph, but looking at carbon dioxide this time, so the tension of carbon dioxide. No difference again between groups at any time point, and the carbon dioxide was significantly lower at 240 minutes compared to 5 and 60. Again, as the residual drugs wear off, the animals ventilate better and are able to blow off that CO2. It's interesting to look at the fact that there were hypoxemic groups, hypoxemic dogs at 5 minutes with a high PaCO2. We would likely put this down to hypoventilatory cause of hypoxemia, but then this black triangle on the right of the graph, where the CO2 is normal, but the animal is still hypoxemic, which would suggest that there's probably another cause of the hypoxemia in this case, because the CO2 has come way down, but the animal remains hypoxemic. I thought the results were quite interesting because for me, there were no statistically significant differences. However, when you look at them in numbers, I think they were definitely onto a trend in this case. So at 5 minutes post-extubation, 3 out of 10 dogs in the high fraction of oxygen were hypoxemic, whereas 6 were hypoxemic in the restricted oxygen group. And then, quite interestingly, at 240 minutes, so way after recovery from anaesthetic, still 3 out of 10 dogs in the 0.4 group were hypoxemic. And I couldn't tease out from their description of the methodology how they classified these dogs as hypox. I think if they had classified or given a distinctive hypoxemic yes or no, I think they might have detected a difference at that 5 minute stage, whereas because they were looking just at the actual value for oxygen tension, I think that's why it wasn't statistically significant. And also at 240 minutes, there was some problem with some of the catheters, so they did actually miss some data points. So in terms of discussion, again, their results did not support their hypothesis. So they found no advantage in using low oxygen fraction with nitrogen as a support gas in terms of post-anaesthetic oxygenation. And in fact, the trend pointed towards a disadvantage of using a low fraction of oxygen, as there were more hypoxemic animals in the 0.4 oxygen fraction group. This could be due to the fact that low fractions of oxygen may predispose to hypoxemia in the event of airway obstruction or accidental disconnection, because your animal has less oxygen within the lung to maintain saturation even if respiration stops, and this will lead to a more rapid desaturation. They also point out that there's a higher risk of delivering a hypoxic mixture when you use low fractions of oxygen during anaesthetic, especially when the gas mixture is not measured, so you cannot measure the actual concentration of oxygen. So they point at a couple of reasons why using a low fraction might be dangerous intra-op, and then the results kind of suggest that more of these animals might be hypoxemic in the post-operative period too. And again, while there are previous studies which show that atelectasis is improved by using nitrogen and a low oxygen fraction in both humans and dogs, this is not translated into oxygenation measurements in dogs in this case. So their conclusions, their occurrence of post-operative hypoxemia was higher in this study than in the one that they previously conducted with similar methodology. And that was why they chose to do this study, because they thought that the diaphragmatic inactivity might cause a greater degree of atelectasis, which the high oxygen fraction couldn't compensate for. I think they just maybe didn't have enough numbers to find significance in this study, even if it would have been significant to refute their hypothesis. So the addition of nitrogen to the breathed gas mixture offered no advantage to the control group in terms of post-operative oxygenation, and that the frequent occurrence of hypoxemia in both groups, particularly considering that they were healthy dogs, should raise concern and question how closely we monitor these dogs when they are recovering from the anaesthetic, because it seems that, especially if they're mechanically ventilated, hypoxemia might be more common than we currently think. So moving on from the first two papers, they have sort of sown the seed that hypoxemia might be more frequent than we anticipate in the post-operative period, and we feel that that might be multifactorial, mainly due or partially due to the shunt caused by atelectasis, and partially due to hypoventilation caused by sedative and analgesic drugs. Reducing the oxygen fraction to minimize this atelectasis and shunt doesn't seem to have prevented post-operative hypoxemia when used as a single strategy. So if atelectasis is developing, regardless of the oxygen fraction you use, and if it has a clinical consequence measured as hypoxemia in the post-operative period, can we deal with that atelectasis in another way? And that takes us on to the third paper. The methodology is a bit different here. This is using patients which are undergoing laparoscopic ovariotomy rather than open abdomen ovariohysterectomy. But I think it's quite a well-designed study, and we'll look through that just now. But just moving on to a couple of other definitions, if people are unfamiliar with these terms, but the alveolar recruitment manoeuvre, or ARM, is the sustained application of a high airway pressure in order to distend the lung parenchyma. So there are different timings and pressures prescribed, but typically that would be something in the region of 30 centimeters of water held for 20 seconds. So you basically close your APL valve, hold the bag with pressure of 30 centimeters water, if you can measure it, for quite a prolonged period of time. And that pops open these alveoli. If you don't then follow it up with PEEP, then any improvement tends to be very short-lived. But in this study, they did the alveolar recruitment followed by PEEP, which is positive end-expiratory pressure. And it's the maintenance of a supra-atmospheric airway pressure